I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
Hello, I'm Dr. Robert Trestman, Chair of Psychiatry at the Virginia Tech Carilion School of Medicine. We're going to be discussing today in Module 1 the challenge of discussing pain with patients, the specific topic of the psychological aspects of pain. This topic 4 is the final topic in Module 1 that we'll be reviewing. Our patients come to us with a range of challenges and impairments. Part of our job is to recognize and effectively engage them in treatment so that we can support their recovery, to minimize their suffering, and to really help them overcome the pain that they are experiencing. In that context, it's important to recognize the high prevalence of co-occurring disorders along with the presentation of pain. And so first, what is the prevalence of co-occurring mental illness in opioid-using individuals? Well, first, depression. Somebody who experiences chronic pain in particular is at high risk of experiencing some symptoms of depression and may indeed have a diagnosable major depression. This is so common as to be almost the norm. 57% of patients who are being prescribed opioids will have some symptoms of major depression, and over a quarter, 27% of our patients who are being prescribed opioids have a co-occurring diagnosis of major depression. In parallel, anxiety disorders and symptoms are prevalent as well at similar rates. Half of our patients who we treat with opioids have symptoms of anxiety disorders. And again, over a quarter, almost 30%, have a diagnosable anxiety disorder condition. My question to you is, are you aware of it? Unless we ask these questions, we will not know that our patients' ability to cope with their pain, to recover effectively, to engage in treatment is severely compromised, and we can make a difference in those comorbid conditions. 16% of Americans who have mental health disorders receive 60 million opioid prescriptions yearly. Fully half of all opioids prescribed in the United States. Having a mental health disorder doubles the risk of prescription opioid use. The odds ratio is slightly greater than twice. And what that means is that we have an obligation to recognize what those disorders are, whether our patients have them, and to get them into treatment or to treat them ourselves, so that not only are they going to be able to recover from the pain. They will be able to engage in treatment with us so that they can more effectively recover, function, and return to their more effective and higher levels of engagement and higher quality of life. This can be looked at in another way as well. Functional impairments due to pain. The light-colored bars on the left-hand side reflect those individuals who we treat who do not have a mental health illness. And you can see that typically much lower percentages of them report self-report limitations due to their pain than do our patients who have mental health illnesses, as reflected in the black bars. So similarly, when we reflect on pain conditions grouped either as cancer-related pains or musculoskeletal conditions that are reflected in the graph on the right side, as you can see, there's a similar pattern where patients with a mental illness typically will experience limitations due to their pain, functional impairment, at about twice the rate of our patients without mental illness. And so it's really important for us to take that into account, to make sure we have assessments in place, whether through self-report questionnaires or appropriate screening and questioning of our patients to rule out the co-occurrence of mental illness. Because unless we do, we are going to definitely be compromising the care that we are providing to our patients. How did we get to where we are today? Why is it that we are facing a pandemic of death and opioid addiction? Well, it's by no means complex. It started in a fairly simple context, tragically. But the waves of involvement of our society and our culture have created the complexity. In the early 1990s, much of this can be traced to pharmaceutical marketing, particularly by a pharmaceutical company, Purdue, who aggressively marketed a new formulation of oxycodone that was designed to be slow-released, and they considered it to be non-addicting. And on the basis of one misrepresented, very small study, they aggressively argued that it was a non-addictive medication. And over time, they recruited over 5,000 physicians to its speakers bureau, handing out all sorts of trinkets, pens, and lunches, and hats, and all sorts of things, as well as providing lavish trips to its speakers to be able to engage clinicians to use more and more and higher doses of this slow-release form of oxycodone. That was bad enough. But in parallel with this, there was another driving force that contributed substantially. And unfortunately, we all participated very actively in this in the early 2000s through the Joint Commission and its accreditation process for hospitals and healthcare systems. Because there was a requirement that we were expected to participate in, that our patients should be pain-free. And to help our patients be pain-free, we were encouraged to use any and all appropriate treatments. And in the acute setting, that was almost invariably one form or another of an opioid medication. And gradually, persistently, and exhaustively, we addicted our country to the use, the routine use, and the overuse of opioids. And because of that, we are now facing a pandemic of addiction, of dysfunction, and of death in our patients that we inadvertently, despite our oaths as physicians and as clinicians to do no harm and to reduce suffering, we inadvertently contributed to this. And so currently, the consequences have been profound. There are public health consequences at the base. Infectious diseases such as HIV and hepatitis C have drastically increased in many of our opioid-treated individuals. The death rate associated with overdose has skyrocketed. More people now have died year over year from overdoses than died in the Vietnam War, or are currently dying from traffic fatalities or from guns. Last year, it's estimated that 72,000 people died in the United States alone from overdoses. There has been profound disruption of our families and our communities as a consequence to this. Many thousands of women are now pregnant and addicted to opioids, leading to a substantial number of babies born addicted and going through withdrawal in something that's been called the neonatal abstinence syndrome. The overall healthcare impact is extraordinary. A few years ago, documented as over $29 billion of healthcare cost. And more recently, just last year, the overall economic impact was in excess of $500 billion. So it is incumbent on all of us who touch a patient to think very, very carefully about our use of opioids, about our assessment of pain, and how we communicate with our patients the potential benefits of treatment and the risks. It's also incredibly important for us to help our patients recognize that pain is complex and that there is a psychology of pain. So it's critical for us to utilize objective data as we make our pain assessments, our risk assessments, our diagnostic assessments, and help also to recognize that patients have a fear of living in pain. So recognizing that will inform our conversations. It's also important to place pain in the context both of the underlying biology and pathophysiology, as well as the human experience of pain and how people interpret and translate that experience of pain into functional impairment. Our central nervous system plays a complex role in this. Our brains are not simple wiring. Our brains have been designed to help keep us alive. They reward us for breathing, for eating, for procreating and maintaining our species. So too do they reward us for stimulating and generating the neurotransmitters in our brain that are released when we take medications such as opioids. And our responses both to those stimulants that reward us, as well as the profound withdrawal effects that drive us to seek medications to minimize the effects of withdrawal, make it so important for us to recognize that there's a complex process in our brains going on that make it extremely difficult for our patients to stop taking opioids, even if the pain stops. So as we work with our patients, keep in mind that when we're prescribing opioids, we need to have an open and honest conversation with them, both about the risks and the benefits and the alternatives to it, engaging them as partners in treatment and helping them have optimism in coping with the pain so that they don't feel alone and abandoned, and that we, as clinicians, help support them in this process and our society in overcoming the epidemic of opioid addiction that inadvertently we help to create. Thank you. This brings us to the end of this fourth topic and the end of Module 1. Thank you.